Kamusta team? It's good to know Wednesday. Our topic today is hyper-K, which is defined as potassium of 5.5 millimole and above. We all know that hyperkalemia can be very life-threatening. It can cause cardiac arrhythmias and even sudden death. But what are the main causes we see in ICU? Let's start with blood sampling. Let's say for example, we manually extracted the blood out of an arterial line. This causes lots and lots of RBC to rupture, and its contents such as potassium released in the serum. Remember, chemistries are checked not within the red cells but rather in the surrounding serum, which means more red blood cells rupture is equal to more K in the serum, meaning hemolyze. So let's take care in getting those red cells out. Another cause of hyper-K is metabolic acidosis. This is the Philippine piso, which nurses remember as potassium in, sodium out of the cell. In metabolic acidosis state, the potassium is now shifted out of the cell and into the extravascular compartment, specifically into the intravascular space, resulting to increased serum K. Renal failure is another cause, as failing kidney will not be able to excrete potassium, hence increasing serum K. On the other hand, a working kidney may not also be able to excrete potassium due to volume depletion. It could also be drug-induced from potassium supplements, potassium-sparing diuretics, and more. Now, let's take a look at the easy changes caused by hyper-K. We all know the sinus rhythm by heart. On its earliest form, hyperkalemia will show a peak T wave, then a progressive lengthening of the PR interval. The QRS duration and the flattening of the P wave will be noticed. On its severe form, around 8 millimoles, there is a loss of P waves, whereby a sinusoidal wave pattern, VT or VF, will be seen. This means worsening cardiac conduction that requires rapid-acting pharmacological measures and a prompt initiation of hemodialysis. So how do we normalize the K in ICU? Calcium gluconate is given to stabilize heart conduction, not decrease the potassium. It is usually given 10 ml in 2 to 3 minutes IV. Salbutamol NEVs decreases serum potassium by increasing the shift of extracellular potassium into the intracellular space. It is usually given 10 to 20 mg intermittent nebulization. We should also correct volume to optimize kidney function. If metabolic acidosis is present, we usually give sodium bicarbonate 50 ml IV within 5 to 10 minutes. Another intervention is insulin and glucose. Insulin shifts potassium into the cells by stimulating the sodium-potassium ATPase activity. In short, this pump exchanges intracellular sodium for extracellular potassium, therefore lowering serum K level, and the glucose to correct the effect of insulin. We also give Resonium A, whereby the sodium will swap potassium into the large intestine. In ALS, calcium chloride is the drug of choice as a protective measure and as the first line of drug during hyperkalemic arrest. Take note, we stock calcium chloride in the arrest trolley, which is threefold higher in concentration than calcium gluconate. And lastly, through the initiation of hemodialysis. Salamat!